Welcome to Talk Dizzy to Me, the show that brings you a comprehensive look into the complex field of dizziness. Now, here are your hosts, vestibular physical therapist Dr. Abbie Ross and Dr. Danielle Tate.
Welcome back to Talk Dizzy to Me. I'm one of your hosts, Abbie Ross, joined today by Dr. Dani Tate. We're both vestibular physical therapists. And today we have back on the show a fan favorite, Dr. Beh, to talk about actually a topic that we get a lot of questions about on our social media platforms and requests to do a podcast about. So thank you so much, Dr. Beh. You're coming on to talk to us about MdDS, Mal de Debarquement Syndrome.
Pleasure. Thank you for having me so soon.
We just couldn't get enough.
They won't leave me alone.
It's okay.
Well, you're such a wealth of knowledge for vestibular migraine. You are our go-to person. And, looking into Mal de Debarquement, there is a very strong correlation between MdDS and vestibular migraine and PPPD. So I think this is very fitting to have you on to talk about this today, because I'm sure you probably see it a lot more often than we do in the clinic. So this would be great.
A fair number. But, quite a few of the patients, actually, the diagnosis is made by our vestibular therapists.
That's good to hear. Well, why don't we start off? Why don't you give us how you explain MdDS to your patients? What is kind of like in lay terms what this condition is, and then we can kind of dig in a little bit more into what it actually involves.
I always tell my patients they have the French disease. The wonderful French name for it. I boil it down to telling them that it's one of the more unusual vestibular conditions, where for some reason, the brain believes that it is in motion, although it's not supposed to be in motion. And so, to me, that's kind of the essence of MdDS.
Absolutely. And especially after this typically comes on after somebody has gone on a cruise, or they've been on long periods of traveling, like a boat, a plane, a train. Sometimes they took a plane to get to their cruise ship and then did island excursions, got back on the boat and came back on a plane. And all of a sudden it felt like they never got off the boat or the plane or whatever transportation they were on. So typically there's some precipitating event of travel or movement that kind of clicks the brain into this mode of we're still moving and we need to adjust. That just never quite goes away. Would you say that's about right?
Absolutely, yeah. Absolutely. The brain adapts to the motion of whatever it's on, right? A plane, a car, a train, long car ride, and then for some reason it never returns to the Earth stable environment. Why that happens to some people and not others, no one really knows. But I think that definition, and it's in the Diagnostic Criteria, right, that just came out. But I think that definition misses the patients that for some reason they have the spontaneous onset MdDS. For some reason, no exposure to motion, but then they develop these similar manifestations where, they feel as if they are rocking in the sea on a boat, and it gets better when they get in a car, when they get back on a ship or they get on a plane, but, they have no previous exposures to motion.
Yeah, let's cover that diagnostic criteria, because to be honest, I actually had to look this up myself to see what that classifying information was. And they just came out with this, I think, in 2020 for the Bárány Society. So first, it's non-spinning vertigo characterized by oscillatory perception. So rocking, swaying, or bobbing, that's constantly there for most of the day. It occurs within 48 hours of exposure to passive motion. Symptom, and this is the big one. I think this is the big determining factor for MdDS, but symptoms temporarily reduce with exposure to passive motion. So like getting back in a car, or a boat, or a plane. And then symptoms continue for longer than 48 hours. So again, this is persistent. Symptoms can last for months, even more longer than a month. You can have some episodes that are more transient that resolve at or before a 1 month, but they're still in this long extended period of time. And some people could be coming to us, within that first month period, which is where we're in evolution. But also it's a diagnosis by exclusion, right? We've ruled everything else out, and these factors make it clear that this is, our situation. Yeah. But that could be a little bit complicated with things like migraine.
Absolutely. I think that the whole diagnosis of exclusion thing is a little bit, tricky there because, then people get misled into thinking that, it's kind of the trash can diagnosis where, all right, it's not this, it's not this, it's not this. And so, the only thing left is MdDS. Right, you have MdDS. Right? But MdDS, it's just pretty characteristic. They have this sense of, oscillatory movement, so back and forth movement, up and down, side to side, forwards and backwards, right? Or a combination of all of that. But the weird thing about it is, it gets better when you are exposed to passive motion again. So, car and all that. I think once you get that history, it's not really a diagnosis of exclusion anymore. With that pattern there, that's so characteristic of MdDS. You'd be like, hey, you got MdDS?
Agreed. 100% agree with that. And you see that little clause at the end of diagnostic criteria for migraine and 3PD, like let's rule and Meniere's, let's rule everything else out. When in reality, a lot of those things can happen in combination or in tandem with one another.
Exactly.
So it's interesting for you to bring up that point, because you're right. Like if I hear somebody had these issues with motion, but it's resolved by movement, I immediately think MdDS.
Yeah.
Oh boy.
Yeah, and actually, when I'm listening to a patient's story, that's really what clues me into MdDS versus 3PD. If it's been going on for a while, that it actually gets better with motion. Because sometimes you will hear in 3PD the same sort of symptom, like I feel rocking, and it's been going on for a while. If it's that type of MdDS, but when they say, "But I feel better when I get in the car," I'm like, "Oh, okay."
Yeah. Whereas 3PD, people typically tend to feel worse when they're ambulatory or up and moving and doing things. So their symptoms are provoked by the things that typically make people feel better with MdDS, which is a big way to kind of differentiate between the two.
Absolutely. I think that's also an important point where people who have MdDS, they actually prefer to be moving around. A lot of the patients say, hey, I do feel better when I'm walking around versus if, I'm in the kitchen and I have to stand completely still while I'm prepping, that to me also points a lot towards MdDS. A fascinating thing is some actually find that, if they walk at a particular cadence that matches their rocking, then that makes them feel even better.
Mm-hmm. It was interesting. I think we'll get into this a little bit more later in the episode, but Dr. Dai's work in the field of MdDS, his team did a big presentation up at Mount Sinai at a research presentation or weekend back in 2019, where they talked about his work and the protocols that went into figuring out how to make these people feel better and how to basically go against the type of rocking and sway. It was mind-blowing, absolutely mind-blowing how specific this can be. But you're absolutely right. They found that matching that person's frequency of swaying or rocking optimized treatment, which is just very difficult to do after listening to what they had to do to match that. So props to them.
I don't completely understand how they do it, but apparently, the reasoning, I think, is you match the frequency and then you hit them with a movement that reverses.
In reverse, yeah. So are they more anterior, posterior? Are they more lateral sway? Is there any sort of orthogonal direction to this? They figure that out. They look at their posturography and then they put them in a full field optokinetic in reverse. So they try to find the frequency of this and then they hit the optokinetics in reverse, which I was like, there's no way I can replicate this.
Not only that, they have to rock the head too. So they I think if it's the rock
in an opposite direction,
they have to go side to side or something. I don't fully understand. If anyone wants it, I say go see Dr. Yakushin in Mount Sinai.
Yeah,
we will link that. We'll link his study as well as the information on how you can get in touch with a patient coordinator, because I do know they have appointments available where you can go up and spend 2 weeks up there and undergo his treatment protocol because it is so specific. It's nothing that we can really recreate.
Yep.
What are you looking for in a patient is there something to look for, I should say, in a patient to know if that type of treatment could work, or is it just, let's try it? Because I do have some patients who found that protocol helped, but then I have others that say it didn't do anything for me. Although maybe I'm seeing them because it didn't do anything for them and I'm not seeing the ones that it helped,
That's true.
But is there something to look for in a patient that would clue you into, okay, let me send you to Mount Sinai?
So personally, I suspect that the classic motion-triggered MdDS would do really well with that. Because, in the first place, what happened is for some reason the brain had gotten entrained to the motion of whatever the person was on. So, that treatment, I think, will help with that type of MdDS. Now, then the controversy comes in where, you bring up spontaneous onset MdDS, right, which, is non-motion triggered. I suspect that group of patients may not respond as well as with the motion-triggered MdDS. I don't have many patients who have gone to Mount Sinai, so I can't. It's hard to make a comparison there, but just based on what I've seen in the few that have gone, the motion-triggered ones tend to respond well. The spontaneous onset ones, for some reason, don't respond as well. Now, if you use the current diagnostic criteria, then our spontaneous onset friends won't be considered MdDS anymore.
That's a good point. So let's back up because we'll get more into treatment, but let's talk about symptoms and things that might potentially trigger what's going on. So this patient comes in, we cover the history that we expect to hear. What are some things that we notice as far as who this affects and what's triggering that? What kind of symptoms are they complaining of, even just besides the rocking and swaying constantly?
So a lot of them also report, for lack of a better term, but a lot of patients use this term, trampoline walking. Now, some describe, the ground feels mushy when they're walking on it, so their feet sink into the ground when they're walking on it. Quite a few actually also describe pulling. So, it can be pulling in one direction, it can be pulling downwards. That gravitation, quote unquote, gravitational pull seems, to be quite an interesting feature. The others seem more not so specific. So, you do have the ones that are, cannot stand head movement, the ones who cannot stand, certain visual stimuli. I do wonder in those people if PPPD side of things already, right? Then you have the ones with light sensitivity, sound sensitivity. Those I also somewhat wonder if, it's more migrainous type of manifestations are beginning in that patient group.
Yeah, that's a good point. And I know there's still like that typical anxiety, more type A personality type of a person that's in on that. And again, you're right with exactly with the potential light, sensitivity, sound sensitivity does sound like migraine, but doesn't quite meet all the diagnostic criteria for migraine. I thought it was really interesting looking at the bárány study or the classification about how this affected mostly women. Almost overwhelmingly, they said reported anywhere between 75 to 100% of people with MdDS tend to be women, which was interesting. And then possible triggering factors could also include hormonal influences like going into menopause or just perimenstrual states, which again, too, we also see with migraine.
Yes.
Or pregnancy.
Yeah.
Yeah. So I have seen patients in whom it kicks up after pregnancy. Or, I've had patients who had very well-controlled MdDS before, and then, after delivery, everything flares up again for some reason.
That's interesting. So what do you do? So realistically, sending people to Mount Sinai is difficult unless you're in New York and you're around the corner, are able to get there. What are you doing for your MdDS patients?
So I find the interesting part, and again, this may be, a little controversial if you want to follow the Bárány Society classification or the diagnostic criteria, right? So what I find to be the more interesting thing is to differentiate them into two groups. Number one is the group with vestibular migraine, and number two, the group without vestibular migraine. I think we published that last year in Laryngoscope about, differentiating these two groups of MdDS patients. So, what I've seen is that people who have both vestibular migraine and MdDS tend to have much worse symptoms to start off with. Right, the DHI scores are far higher. The reported impact on their jobs are much higher. Anxiety levels much higher as well. The interesting thing is that they also seem to do better in terms of treatment. The most of them tend to do better with migraine type of treatments, whereas the classic MdDS or even spontaneous onset MdDS without any vestibular migraine features, although their symptoms are not as severe to start off with, they tend to do more poorly. They don't respond to treatment as well from what I've seen so far. The usual treatments, definitely are like the antidepressant medications, the benzodiazepines. We use those quite frequently in MdDS. The difference I would say is, those with features of vestibular migraine, I would also use migraine preventive treatments for them. Now, could we potentially use migraine preventive treatments in people without features of vestibular migraine? Definitely, that's very possible there. It's just that we haven't done a study just to look specifically to see, if you treat an MdDS patient who has no features of vestibular migraine, if you treat them with a migraine preventive, would they still get better? We don't know.
Interesting.
That's really interesting.
Yeah. So, in my experience in VRT, I don't know, MdDS is a tough one. What is your thought on recommending VRT for these types of patients, or does it vary depending on the symptoms that they present with?
I think it varies. So, if you talk about just the rocking itself, that's a tough one. I agree. Just the rocking, swaying, bobbing, I don't think, traditional VRT helps them that much. Now, if they start to develop head motion triggered dizziness, if they start to develop features of PPPD, or if they start to do, unusual types of walking, because of the rocking, then I think that's when, VRT becomes very useful to help them get out of those patterns.
I think that's a good point. I recently had an MdDS patient who found me through, I think, the Vita provider directory, right? And then we talked for a little bit, and he ended up being local to where I was working up in Hilton Head, South Carolina. And it was interesting. He had that bobbing, swaying, rocking, which, I try to set expectations and go, I'm not really sure if I'm going to be able to help with that at all. But after doing a full evaluation, found some other deficits like difficulty with head movements during gait and it's kind of functional balance stuff. And as we progressed through treatment, we did a lot of habituation, but we also did a lot of vestibular, rehab and just functional balance on different surfaces. Functionally, looks so much better. He could finally stand with his eyes closed and be still, looking at him. He could stand on foam and not be swaying and moving all over the place and trying to catch himself. But internally, he felt exactly the same. So whether or not we consider that successful treatment, I'm not sure. He felt grateful that he was walking better and that he was able to function more. But he still had those symptoms that brought him into my clinic. And that's where we go, okay, I set the expectations from day one. I said, I'm not sure if we're going to be able to do this. Here's what I'm finding. Let's see if we can fix that. And then we'll go from there. And he actually, I believe, might be going up to Mount Sinai. He's been looking into going into doing a couple of weeks up there. So I'm still waiting to hear back. But it was just interesting. When we get these calls for MdDS patients, we usually this is the one diagnosis where I'm like, oh, can I really do something about this? Because I know the reason why they're coming in is not going to be the thing I particularly help with. So there's a lot of patient education there. And if only every state had a guru like you that we could get people to, I think that would be extremely helpful.
I can't do Dr. Dai's treatment. I don't have the knowledge.
Oh no, but even just medical management, it's amazing how many people, one, don't specialize and treat migraine or 3PD patients or MdDS patients well. They don't they don't get diagnosed easily. And by the time they do, it's very chronic. And it's usually at some clinic where they don't do regular follow-ups. It's more of let's do every test under the sun, get you diagnosed, and then have you figure out where to go. It's that medical management that I think a lot of people miss out on because drugs can be extremely helpful, the right set of drugs and the right approach to treatment. And unfortunately, that is not comprehensive everywhere. So that could be, I think, part of the missing link of people that suffer from MdDS is having that.
That is true. I've seen the few patients, they actually been diagnosed with MdDS, by a physician, but then they're told nothing can be done. Goodbye.
Mm-hmm.
Nope.
I should give a shout out here too. She'll be on our show soon as well, but Dr. Catherine Cho is very good.
Hey,
at NYU.
The guru of MdDS.
Yeah, so if you're in New York, Dr. Catherine Cho is also another good resource. But, Dani, I think sometimes our role too, and we've talked about this before, is more the educational piece. Mm-hmm. We might not be able to help the rocking per se. I did have one patient though, miraculously. I don't know what happened. I don't know what I did, but when her other deficits and symptoms went away, so did the rocking. So I was like, all right, I don't know, but we're going with it.
Well, it can spontaneously resolve, correct? Like, I mean, this is something that can go away in a year, or it could be present for 10 years. It's hard to say.
I think one of the original studies, they showed 6 months to be the cutoff time. So, once it persisted beyond 6 months, the chances of spontaneous remission very low.
Wow.
I did not know that. That's a good thing that's a really good thing to know.
Yeah.
But that's without treatment. Though.
Yeah.
So that's, that's also something I remind our patients, saying that, because they read the same thing and then they think, oh my God, I've had this for more than 6 months. I'm going to live with this my whole life. So you never have to remind them that was a study done without treatment. And so, I tell them there's no studies yet into, like if you treat it, is there a particular duration during which, it won't go away, or will it go away? We don't know.
Yeah, it's interesting.
What percentage would you say of patients that you see do you actually diagnose with MdDS?
It's more lately for some reason. I'm noticing it a bit more. I think it just could be sampling error. But, lately I've seen about 20% of the patients I've seen lately, the last, I would say, 3 months, have been MdDS diagnoses.
It may be because we're sending you everyone we can't help.
Could be.
Now, I mean, this is something that so that's what I want to touch on. This is something that I've kind of, I keep coming back to, but I think we keep seeing this new skew of data and diagnoses in vestibular patients because we have not been moving this last year. I mean, COVID has kept people from moving regularly. They've been home. They haven't been out and about. They haven't been able to participate in the things that they would normally do, like group exercise classes and yoga, even something as silly as water aerobics or just walking around their neighborhood. We're not moving. So I feel like there's got to be some component of people being more affected due to decompensated vestibular systems. Potentially.
Yeah. The stress of, the lockdown too, there's one issue there. They see two populations of patients, I think, when it comes to the vestibular disorders with vestibular migraine. You have the one group that's like, oh my goodness, I'm home. I don't have to go out anymore. I don't have to go to work. Great. Everything gets better, right? Then there's the other group that, they cannot deal with the stress of being, locked up at home, or the stress of having to use, Zoom calls all the time, and the motion and everything on the screen, which, aggravates the symptoms significantly.
Well, even the people that have been loving being at home, now they're saying, oh my God, I haven't been out in the community and living a normal life in so long that going to the store is difficult again, that they have to build this back up. So all of a sudden they got so comfortable being in their bubble. Like, my symptoms were so manageable. I felt great. And now that I've had to re-enter society, it's like, boom, everything's blowing up again. And it's hard to start all over. Like, it's amazing how COVID has really kind of turned this all on its head, especially after vaccination now, with people having issues with tinnitus and dizziness. I mean, Abbie, people are still commenting on our COVID episode about being dizzy. There's almost a new comment every day about, I got the vaccine and now I'm dizzy, and going on and on and on. It's amazing.
It's a little bit controversial, right? Because, well, we don't need to get into the controversy, but
I think it's important to address it. So that I have questions from patients about the same thing too.
Yeah.
So in the patients that I have seen, those that actually have caught COVID, uniformly, regardless of whatever condition they have, MdDS, PPPD, or vestibular migraine, all of them suffered much, much, much horrible worsening of their conditions after catching COVID, right? Now, the people who got vaccinated, a small number did actually get worse. So, it's related to how they react to the vaccine. So, if they get a more robust immune response, more flu-like symptoms, more fevers and stuff like that, then their symptoms did flare up. So I remind our patients that say, because, they are afraid of that, I tell them, if you catch COVID, chances of things getting worse is extremely high. Right, but with the vaccination, it's lowish. So you just have to weigh. You just have to weigh. What you prefer.
Yeah, exactly. we went through great lengths to make sure that we were not telling people not to get vaccinated, that things are going to be significantly worse if you catch COVID. But the fact is that we're starting to see, especially there's different categories that we covered, but my more central vestibular dysfunctional patients tended to have the reaction following vaccine that knocked them back a couple pegs. But they were able to recover for the most part. But they did have a bit of a different reaction versus people who were getting vaccinated and just having an increased incidence of tinnitus or this weird, very slight hypofunction type of appearance. It's just been, I mean, from being in lockdown to decompensating to now having post-COVID symptoms and post-COVID vaccination symptoms, we're looking at a whole new category of people and issues. And it's definitely becoming more talked about. People are raising more awareness about vestibular dysfunction, which has been kind of nice to see, but also in the wrong context. We don't want people to get dizzy.
Yeah. And when a patient asks you, could this be because of my vaccine? I swear it's because of the vaccine. It's hard. You always say, there's no way for me to know exactly, but it's possible. It is possible. And the other thing I wanted to say is those patients that you were mentioning that look more like a hypofunction or, have dizziness with movement now that wasn't there before, they have anecdotally responded well to short courses of VRT. So that is a positive if you're listening to this.
Yeah. I mean, I know this episode, we were kind of avoiding this topic for a long time because it is kind of doom and gloom, so much so where we can't give them as much hope as curing BPPD. But MdDS is something that's still needs to be vastly studied. It needs to be understood a lot better. And we need to come up with more treatments because we feel so terribly when we can't help patients the way that they want to be helped.
Recovery are good though. That's the thing. Yes. A lot do get better. It can be tough. It's tougher to treat compared to, say, triple PD or even vestibular migraine. But, I tell my patients still, chances of recovery, pretty decent.
Yes, especially with a multidisciplinary approach, right? Absolutely. Abbie and I are the first ones to tell you physical therapy is not going to be the only thing that solves this.
Some also need CBT, psychological, interventions that also would help.
Mm-hmm. Right. Absolutely. That is a big component as well. Well, Dr. Beh, we thank you so much for joining us on this hot topic. Like I said, you're going to make a lot of people happy because we've been getting asked to do this topic for a long time now. Is there anything that you want to put on the table in terms of where people can find you, website, contact information, what's going on in research world, anything like that?
Twitter, easiest way to contact me, the Dizzy Doc. And, website is vestibulo-md.com. The research-wise, I think there's a lot that's very exciting that's going on. One of the interesting things, that's been presented is looking at maybe one of the reasons for MdDS is, somehow it entrains the oscillations in the cerebellum to, the movements of a vehicle. And that's the cause of MdDS. Fascinating, right? Wow. So, one of those, I have found to be quite useful for preventing the flare-up for MdDS is, benzos. So I do have patients who have to travel frequently, a little bit lesser during COVID, right? But before COVID hit, they had to travel for business and everything. Give them a little bit of benzos before they travel. Seems to prevent it from flaring up.
That's really interesting. That concept that you mentioned, that was in one of Dr. Dye's earlier papers, right? The idea that the VOR has to adapt to movement. Like if you're on a boat with the rocking, it has to readjust. It just never goes back to the new normal when you hit dry land, right?
Absolutely. Yep.
Yeah. It's nuts.
Yeah. Thomas Brandt, I think Dr. Brandt in Germany, he also proposed something very fascinating. He said that, I think one of the possible reasons for MdDS is a hallucination. It's the vestibular system's hallucination. It's still dreaming that it's on a boat.
Wow. That is interesting.
Huh. Very interesting.
Oh, that's so cool.
It's fascinating condition. Super fascinating condition.
I'm interested to see how our listeners react. Depending if we get on a lot of questions or something, maybe we can do a live follow-up episode or something along those lines. But this will be interesting.
You have to ask, I think you're interviewing Dr. Cho, right?
Yes.
Mhm.
I always get confused whether it's Dr. Cha or Dr. Cho who did the research into transcranial direct current stimulation and transcranial magnetic stimulation. So that's another interesting application too, where, it would be easier to do than, Dr. Dai's protocol. But I think either one of them, I forget who, did those studies where, they zap the dorsolateral prefrontal cortex and, reduce the symptoms. Yep.
That would be interesting.
Fascinating. No.
They got a lot of stuff coming out that's really different and interesting, and it seems to be working. So whether they're using like an electrical stimulation, I've even seen vibration being used to help mitigate motion sickness and dizziness. There's a device that these guys are working on in DC that it's very interesting. We should really get them on, Abbie, and talk about that.
Where does it vibrate?
It's so over the mastoid, either side. Have you heard of these guys? They've created something called the Oto Band. They're Otolith Labs, and they're a company in DC. And it's something that when it was first described to me, I'm like, I don't think this is going to work. And then it really does seem to. They're running studies.
If you vibrate, you basically are stimulating the peripheral vestibular system.
Yep, but very, very low frequency. I think it's very low frequency. You can once it's on for a while, you don't even feel it. You don't hear it, but it's similar to putting your head against a car window when you're motion sick.
Interesting.
So, and they've already run some preliminary studies. They found that it has greatly reduced people with chronic dizziness by over 50% on their worst days. I've strapped it on and I've laid down in the back of the car while reading a book through windy mountainous roads, and I didn't get motion. I mean, there's a lot of cool stuff coming out, and we need to have an entire episode just on devices and fun stuff because it's cool.
Sounds more fun than the skull vibrator I use is more obnoxious. That one, your eyes also jiggle with the vibration.
What brand do you use for your skull vibration? Because I use that for skull vibration induced nystagmus testing, and it's hard to find the right one that's at the right power that doesn't look scary to the patients.
It's just little Brookstone $20 Brookstone muscle massage.
Perfect.
They don't sell it anymore, unfortunately. The ones they sell now they look a little suspicious.
Getting them on the order list for some companies that I've worked for have given me a lot of dirty looks when they've researched into it. So I've been resorting to the little mini massager that occupational therapists have been using, but I know it's not as strong as it needs to be as some of the other ones that are out there. But I do know Jeff Walter uses the magic wand up at his clinic, and you pull that. They pull those things out, and patients' eyes are like, "What are you doing with that?" So I'll have to look into something similar to your Brookstone muscle massager.
That's funny.
They used to recommend that for patients who couldn't pee. The MS patients, when I was doing MS, we recommended to our patients for suprapubic stimulation to empty the bladder.
Yeah.
It does a great job. It gets the job done for testing purposes. But like I said, I usually keep patients with fixation blocked before I put that out to vibrate mastoids.
Oh, goodness. On that note, I simply can't believe.
Thank you so much again, Dr. Beh. This was so much fun. And we look forward to anything else that we can talk about with you, because it's always been a great episode working with you.
PPPD next time.
Count
Yep.
We'll give you longer than a month this time, though. We'll touch base in a couple months.
Absolutely. Anytime. Triple PD, I think, would be a fun one to talk about.
All right. Thanks so much, Dr. Beh.
Thank you,
everyone.
Good night.
If you're interested in finding us on social media or the web, you can visit www.vestibular.today for more resources, including testing, treatment, and educational videos, blogs, continuing education classes, and resources including clinic equipment recommendations, suggested tests, and BPPD treatment charts.
Search Vestibular Today and Balancing Act Rehab on all social media platforms, including Facebook, Instagram, Twitter, and YouTube. Also, be sure to check out Balancing Act Rehab at www.balancingactrehab.com, especially if you think you would benefit from vestibular therapy. We are your girls. The information on this podcast is not intended to replace the care provided by your qualified health professional or to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on Talk Dizzy to Me. Please contact us at Balancing Act Rehab if you think you could benefit from vestibular therapy.